Hi, everybody. Today's topic, the question that I'm going to answer is what is goofballing or what is speedballing? For those of you new to the channel, my name is Dr. B. This is Dr. B Addiction Recovery. This is a nonprofit endeavor aimed at educating the public in regards to substance abuse. If you do like the content, we do have a Patreon account for as little as $3 a month. You can help support our endeavor. Let's get started. What is goofballing? What is speedballing? That is the question that was presented to me. In the broadest sense, it is the mixing of stimulants with an opiate, which is sort of a depressant. Traditionally, the term took off as speedballing, and it referred to the mixture of cocaine and heroin, or crack cocaine and heroin, through an intravenous injection. Over the years, as generations have gone on, it's more often referred to with methamphetamines, the same concept, and they call it goofballing. I suppose it's goofy because you are putting an upper with a sort of a downer. In practice, this is done in various forms, and it could be done in many ways. For example, you could have heroin intravenous, and then you have a chaser of a stimulant, whether it's methamphetamines, whether it's prescription stimulants ground up, whether both drugs are taken intranasally. There's multiple ways to do this. The idea is to have a stimulant and an opiate pretty much together at the same time, or the stimulant immediately after the opiate as a chaser. One particular cocktail of this, which they often call it the steroids of this kind of thing, is fentanyl and cocaine. Okay, I think it's referred to super speedball or super goofball, and it could be particularly deadly, especially if you get the mixture and the combinations from. I think the more important question is, and it goes at different levels, why is the user doing this? And this can get pretty complex, but let's break it down into a few things. The first one is the idea of a push-pull concept, and it is basically this. The opiate has a quick rush, a euphoria, and the tail end effect of it, which is quite rapid, is fatigue or nodding off or being drowsy. Whereas when you add the stimulant, you are sort of adding a burst of energy to that euphoria. And depending on the stimulant you use, it's much longer lasting. In particular, if you're using a methamphetamine product versus cocaine, it's going to last quite a long time. That's one reason somebody may do this. Another reason why somebody may be doing this is the misconceived idea that they will not overdose from the opiate. And this is also wrong, very wrong, and a deadly reason to be doing this. Here's why it's wrong. Depending on, you can both overdose on the opiate, or you can have a severe medical event happen from the stimulant. From the opiate, depending on how long lasting the stimulant is, cocaine versus a methamphetamine, the effects might wear off very early on, and the respiratory depression and the stopping of breathing can occur because of the opiate. On the other hand, having a stimulant on there and having so much metabolic and physiological stress on your body can not only have an effect or an event occur with the stimulant, heart attack, stroke, gut attack, and many other things. It could also be exacerbated and your threshold lower by the kind of imposed metabolic stress of the opiate. Another reason might be that the user at this point, which is very common as you start to use longer and longer, depending on where your addiction and the disease is at, is you're chasing a better high. As you know, as you continue down the road of your addiction, your threshold for the effects you got early on keeps decreasing, and you need more and more of the substance. Now, whether that is simply because in your mind you're chasing a high, you're running away from something, there's emotional pain, trauma, whatever it is, that particular reason that the addict became an addict in the first place continues to escalate in its natural order, and now they may be using or introducing uh, another substance into the equation to get that high. It's often called chasing the dragon. There's no such thing as a dragon. You're going to chase it forever into jail or into a grave. The final thing is just simply worsening judgment as the disease of substance abuse or addiction. It's taking its toll on the supratentorial structures, the frontal cortex, the midbrain, the executive function, where there is worsening judgment, because it almost seems ludicrous to make a decision to take a stimulant and at the same time take an opiate and inject it into your body. And all of these different factors sort of work together. The idea of thinking, I'm not going to overdose, the idea of chasing a better high as there's more desensitization of the receptors, the idea of the push and pull, trying to get the perfect high, and worsening judgment. All of these can work together. Now, the next area we want to discuss is what are the health consequences on your body, your mind, your short-term and long-term addiction when you do this. Obviously, when you're elevated to a level where you're doing something like this, the robustness of your disease is much greater, right? You can almost say, if we were going to compare it to heart failure, you can say you have worsening heart failure in a way, and it's going to be that much harder to treat. There's obviously a higher chance of overdose. And I want to point something out here on this issue. When they're counting up a lot of these overdose counts for opiate overdose, heroin overdose, fentanyl overdose, we have to keep in mind that these are this would be called polysubstance abusers, okay? And it's really complicating that number, because when you have a polysubstance abuser, now the effects on the body are not the same as just somebody doing an opiate, for example, or heroin. You have multiple substances, and we don't know oftentimes in a formal, detailed, mechanical way how this contributes to overdoses, okay? So you have worsening disease of addiction. You have a greater risk of overdose. And with these folks, you have also even a higher chance of HIV, hepatitis C, soft tissue infections, endocarditis, all of the host of diseases that come with intravenous drug use and addiction in general. You're actually increasing the chance, the rate of all of these things becoming realities. And this has a lot to do, not just because you're using two substances, or in some cases, three substances, but simply of your declining judgment and choices that you make. You may now have so much disease severity, whereas if you recall, there was a time you may have said, hey, I'm never going to put a needle in my arm. Well, you're long past that at this point, often, when you're doing something like this. Now you may be saying something like, I would never share a needle, or I would never put a dirty needle in my arm. Well, now, for a whole host of reasons, including just much worse mental health, declining capacity for good judgment, declining capacity for controlling your impulses, your urges, your needs, and your general cognition has really more than likely declined even more. So you are more than likely to pick up a dirty needle. I've even heard of guys in prison telling me they didn't think twice about sharing needles with somebody who they knew and had admitted they had hepatitis C. Let's move on to treatment. Those are the health consequences, short term and long term. Uh, Treatment actually for these folks is much more difficult. Okay, they have a higher rate of treatment failure, whatever that may be. Keep in mind now you are dealing with stimulant abuse and you're dealing with opiate abuse. If they're going to their traditional treatment route, it's just not built for treating polysubstance abuse. And most people going into treatment now are polysubstance abusers. Let's take this one issue, whether the person is actually using a stimulant by itself quite regularly and an opiate by itself quite regularly, or if they're mixing the two and speedballing or goofballing intravenously, intranasally, whatever. You are dealing with the addiction of two different substances. When you go into detox nowadays and conventional insurance pays for it, this is a tug of war of the treatment facility trying to get days and the insurance company trying to cut days. So, in terms of detox, whatever that means, which some of you may know, I actually don't ascribe to that term. I call it medically assisted withdrawals, and that's what I believe the ruling bodies are calling it now as well. You get 10 days of detox. What happens there? How is this complex disease treated within 10 days in its most acute way? If we're talking about getting some comfort for the acute withdrawals, in addition to the fact that it's 3 days, 5 days, 10 days, most of the treatment out there, I don't think address this correctly. So that's your first 10 days. And then what are you going to get after that? Oftentimes people get 10, 15, 20, 30 days, maybe if you're lucky, 60 days of what's called residential treatment within a facility. Well, at this point, how is your quote unquote detox going in terms of your cravings and your withdrawals? Usually pretty poor, and usually the medication regimen, I think, is probably incorrect, and you haven't even gotten a second to touch the deeper underlying issues that brought the patient to this situation in the first place. And then from there, you go to what's traditionally called partial hospitalization, intensive outpatient, and outpatient. And, what should really be anywhere from 6 months to 2 years of robust treatment is cut down to, like I said, 15, 30, maybe 60 days. And then what happens? And in this whole shuffle, programs are changed depending on payments. Physicians are regularly changed. And the last thing you want in this chronic disease issue that is so complex and deals with more than one substance is a change of physicians. And the patients eventually let out. And, if they make it that far, and oftentimes there's relapse and there's the vicious cycle of going back in. What should really be happening, in my opinion, and the approach to treatment in my ideal setting is oftentimes it shouldn't be divided up into detox, uh, residential, partial hospitalization, intensive outpatient, OP. Uh, it should really be looking at the patient and see where they can do this, whether it's at home, whether it's coming into a program every day. None of that really matters. It has to be tailored. But in terms of the medical part of it, one way that I like to do it is I like to take a look at what do I have in my medical arsenal to treat which drug first, at the same time judging what's going to kill them. I have medication assisted treatment, which I can really start immediately for the opiate part. And if you can do that, whether they're mixing the drug and goofballing or speedballing it, or whether they're taking care of it, I often find that what I've done immediately is mitigate the risk of overdose from the opiates. Great. And I've actually taken care of potentially in many patients a good chunk of the anxiety and potential need to add the stimulant to this cocktail of deadly polysubstance abuse. Okay. And so from there, and I'm going to take an extreme example. I'm going to take one that doesn't really have insurance and can only be seen as an outpatient in my office. So I try to get this monster of the opiate addiction under control as soon as I can. Why? Because they can easily overdose off the opiates. Two, the medication that I have works for the opiates, and it might lend itself to some extent from a certain degree of dosing, in particular 16 milligrams and higher. It might actually help with the methamphetamine. So I get the opiates under control, and little by little, I have different methods and ways to start decreasing the methamphetamine use on their side if I can't get it under control immediately. And over time, as I can do that more and more and more, then I start to address the other issues that are underlying this, the first layer of issues: anxiety, insomnia, depression, panic attacks, and sometimes Axis 1 disorders. Because when this is happening, you can't come in there and tell me, I need something for anxiety, I need something for sleep, and my response will be, well, stop doing methamphetamines, let's get that under control. So once I get the opiates under control, then I start working on the methamphetamine. Then once I get that under some control and can discern and weed out the other underlying issues, like I said, anxiety, depression, insomnia, or some Axis 1 things, and in some cases, different elements of psychotic disorders, whether it's meth-induced or otherwise, I start getting those under control. Once I start to get those under control, now we go down to the real deep dive work of what is it that caused those things in the first place. Are we dealing with complex post-traumatic trauma? Are we dealing with an adverse childhood event? Are we talking about traumatic assault as an adult? And all of these kind of get evaluated. And to the extent that the patient can, I start to plug him into our programming or other places so they can get help for those issues. And if they can't and they don't have the resources, we have a very honest discussion about this. And I find that over time, we can get quite far just through medical office visits. And I think this method works. You have to curb your expectations of a quick fix because it is a chronic disease. You have to apply what I call a harm reduction approach. You know, the guy's been doing meth and he comes in for a Suboxone. You can put some screws on him and demand more engagement, increases number of visits, but to cut him off is just sending him out there and having him relapse in a worse way. And then you need to appreciate the value of time and constantly staying at it to get him to where you need to. In this way, you do get results. It's been proven in the past. You spend much less money utilizing resources and you make the world a better place. If you like this video, click above to my left to see other videos like it. Please don't forget to subscribe and push the thumbs up button, and I'll see you guys soon.